Hi, good evening everyone. Welcome to Unacademy, where you can crack all NEET PG exams with us, with our top educators, quality content, and you can have a great learning experience. So guys, let's crack NEET PG. A little about me. I'm Dr. Sasha Remedius. I've done my MBBS from Father Muller Medical College, Mangalore. I've done my MD in anesthesiology from Father Muller Medical College, Mangalore, and I have 2 publications and 1 paper presentation uh, in the field of anesthesia. I have been working and teaching in Bangalore for the past 2.5 years. So today's topic, I've after a little research, I've put together a few MCQs on neuromuscular junction and muscle relaxing, basically the depolarizing and the non-depolarizing drugs. These are the drugs which muscle relaxants, which act at the neuromuscular junction, and I have taken these classes previously, so I have put together a couple of MCQs, and we shall go through them. Now guys, a little about Unacademy, one of India's largest learning platforms where you get plus subscription and access to unlimited live and recorded courses from India's best educators. So guys, don't delay, get your subscription, start preparing for a NEET PG now itself. So what will you get out of Unacademy? So there are daily live classes, and where you can chat with your educator, engage in discussions, ask your doubts and answer polls, all while the class is going on. So what happens when you go to let's say a coaching class, a coaching academy? So first of all, you waste time, the travel time that you waste, the energy that you waste traveling. You all have to reach there. Then again, the seating arrangement, these are big classes, whether you get placed in front, whether you can hear the educator, you're not sure about all this. Then while the class is going on, while during the class, whether you can clear your doubts. So these are big classes, and as a result, these are really big classes, and so it's difficult for the educator to clear everybody's doubts. So not everyone's doubts will be cleared, so it's difficult for an educator, it's difficult for you to get all your doubts cleared, because not everyone can reach out to the educator in a coaching institute, right? So, and plus, like, your doubts might not be cleared then and there, even during your quizzes, tests. I mean, you need to wait for the results to come, and it's all, it takes time basically and energy. Whereas over here, you can chat with your educator while the class is going on, engage in discussion, ask your doubts, and all this, like I said, while the class is going on. So there are 3 types of classes. We have our YouTube classes, our special classes, and our subscription classes. And during your special classes, there is a marathon that is going to be conducted on Sunday, where all the educators will be taking a subject, completing the subject, a particular topic, not subject, I'm sorry. They'll be completing a particular topic in their respective subjects. So it's a marathon session. They'll take it at one stretch, or, maybe with an hour in between or something. So this is all. So these are special classes that will be conducted on Sunday. So please, guys, don't miss out on those classes, as particular topics will be covered on Sunday at one stretch in various courses. So, like I said, so YouTube special classes, at the side we have a place where you can chat with your educator, and your educator can then and there respond to your queries. And these these YouTube classes, basically post class, we fall back and we try to respond to your queries, and we will respond. So these are all structured courses, that is, they are in line with your exam syllabus to help you best prepare for it. And so we have researched on all the various course structures, and hence we try our best to help you all, so that you all are well prepared for the course. We conduct live tests and quizzes which help y'all, not us, evaluate your preparation. So we prep, like today I've prepared a mock test, a quiz, and so you can evaluate your progress. You can get a detailed analysis, so based on what I have taught you or what you all have gone back, read up again, so based on that, whether you all can answer or not, you all can gauge your performance. And of course, you all have unlimited access. So one subscription gets you access to all our live and recorded courses, and all this you can do, you can watch from the comfort of any of your devices. So wherever you are, wherever you're sitting, wherever you are staying, so in the comfort of your place, and any of whatever device, whether you're using a mobile or whether you're using your iPads or your laptops, you all can watch it from the comfort of any device. These are some of our top educators. As you can see, Dr. Nikita Nanvani, she's a PG mentor for radiology as well as mnemonics and concept focusing on must-know topics encompassing all subjects. Dr. Mohammad Azam, Dr. Divesh Mishra, Dr. Preeti Sharma. So these are the various 19 topics, subjects that are covered, and various courses under these subjects that are covered, as you can see on the screen. These are some of our ongoing courses on our platform. As you can see, neurophysiology, pathology, respiratory system, larynx, cardiovascular, thoracic, course on GI surgery. Now coming to the subscriptions, the most important of all. So as you can see, there are 5 types of subscriptions. Now, like I previously showed you all in my slide, NEET PG has 19 subjects. These are not small subjects, as MBBS is, they're not small subjects, they're very vast subjects. To complete these subjects, to go through all these subjects in 6 months is really not practical. 1 and 3 months, so again, obviously not practical. So I recommend that you all go for the 12 and the 24-month subscriptions. Okay, so 6 months, I'm not saying it's impossible to cover those subjects. It is possible, but if a thorough understanding, a more 100% surety is there if you take I mean, a 95% surety is there if you take 12 and 24 months into consideration, as you have time to prepare. It is a more structured manner in which you can prepare. We are helping you prepare, and you all can it's very important to make your timetables and prepare according to that. It's very important to revise and do tests, quizzes, not just listening to classes. You need to go back, you need to read, you need to go through quizzes. All that takes time, right? There are 19 subjects. So 12 and 24 months are the ideal subscriptions. Also, it is very economical. Now, why economical? So economical in the sense, you know, it's um, it's a one-time subscription, right? Now, after 6 months, your subscription expires. You cannot come back. You cannot go through the test. You cannot go through the recorded classes. So you need to subscribe again. But with the 12-month subscription, it's a one-time subscription. So you have 12 months, you have enough time. And even with the 24, so not everyone, okay, if you feel that not everyone feels that they can clear in the 1 year or 6 months. You need more time. Perfect. Knowledge is always good. There is nothing wrong in taking your time, reading, researching, and preparing for your entrance exams. There is nothing wrong. It's perfect. It's amazing, actually. So 24 months too. It's a one-time subscription, and you have 2 years at your disposal. And as I said, there's renewal, constant renewal on the platform, right? So in line with the NEET PG, we are constantly renewing everything on the platform. So it's perfect. So guys, use my code, as you can see at the bottom of the screen in red, SASHA, and subscribe. You will get a 10% discount. So hurry, guys. And again, for the 24 months, you can see my code at the bottom of the screen, SASHA in red. If you use my code, you can avail a 10% discount. So guys, hurry. Let me start helping you prepare for NEET PG. So coming to today's, so I will be dealing with today the MCQs, as we have discussed. Neuromuscular junction is it is basically the synapse between the nerve and the muscle, where the acetylcholine receptors are present. Acetylcholine is the main neurotransmitter. When acetylcholine is released and binds to these receptors, muscle contraction takes place. Now, muscle relaxants, depolarizing and non-depolarizing muscle relaxants, have the mechanism of action around these receptors, and and how they act, I will as the class is going, I shall explain to you how these receptors act. So, and basically these drugs block these drugs block the action of acetylcholine at the neuromuscular junction, prevent muscle contraction, hence induce muscle relaxation, and it becomes an optimal field for the surgeons. As well as for tracheal intubation. It leads to ideal conditions. So I'm going to keep a stop watch for, I'm going to give you all 1 minute, and then we will discuss the questions briefly. I hope you all are prepared. I think there are roughly around 40 questions that I have prepared for you all. I'll discuss whatever I can about the each question, so that you all can brief, at least brief. It'll be a brief revision for you all. So I don't have time to discuss everything in detail, but I will do whatever I can. Okay, so just a sec. Okay, so the first question: which of the following factors is not related to muscle relaxant? So basically, over here I'm talking, it is non-depolarizing muscle relaxant. So, and your time starts now. Okay, I'll give you 45 seconds. So, and then we'll discuss about it. Okay, so the answer is number 4, MAC. So effective dose ED50 is basically the dose that produces paralysis with respect to, basically an endpoint with respect to these drugs paralysis in 50% of subjects. Okay, so the dose, if ED50 is the dose that produces paralysis, basically muscle relaxation in 50% of test subjects. Priming dose. So what is priming? Priming is a technique where a non-depolarizing muscle relaxant, okay, about 10 to 20% of the ED95, that is the dose that produces paralysis in 95% of the subject. So 20% of the dose, basically this is your intubating dose, or the dose that will cause complete paralysis. So initial 20% is given of the dose. This reduces time to intubation. So basically when we the peak effect is seen of these muscle relaxants, intermediate acting muscle relaxants is seen, this is for intermediate, is seen after about 3 minutes. So when you give 10 to 20%, when it is given around 60 minutes prior to the complete dose, so when this 10 to 20% is given about a minute prior to the entire dose, the trachea can be intubated within 90 minutes. You don't need to wait for 3 minutes. So train of 4. TOF is basically a neuromuscular monitoring. Neuromuscular monitoring, known as train of 4. Train of 4. And it is used basically for assessing depth of anesthesia, It helps in recovery, as you know when to give the neuromuscular uh, the reversal agent, the reversal agent which leads to recovery from neuromuscular paralysis. So and it also determines the potency of a neuromuscular blocking drug. So this is your train of four. Basically, the train of four. In with the depolarizing relaxants, you will see no fade. So four stimuli are given of 2 hertz each, and when there is no fade, it is a depolarizing relaxant, and with a non depolarizing muscle relaxant, you will see a fade in the ratio. And the ratio basically tells you, so the ratio is basically the first to the last. So I'm sorry, T4 by T1 is the train of 4 ratio. So higher the train of 4 ratio, 0.9, that is, it is ideal to reverse the patient out of neuromuscular blockade. So the depth of neuromuscular blockade is inversely proportional to this. The higher the ratio, lesser is the depth of neuromuscular blockade. Lower the ratio, more is the depth of the neuromuscular blockade. This is seen with non-depolarizing drugs. Depolarizing drugs do not produce a fade because the mechanism of fade is at the presynaptic receptors, whereas succinylcholine acts only on the postsynaptic muscle receptors. Presynaptic nicotinic acetylcholine receptors are located on the nerve. So succinylcholine phase 1 cannot act on the presynaptic receptors, but phase 2 has a mechanism at the presynaptic receptors and can produce fade. MAC is nothing but minimum alveolar concentration. MAC is nothing but minimum alveolar concentration. Okay, minimum alveolar concentration is MAC, and it is basically when a patient is basically induced surgical, there is no, in 50% of subjects there is no response to surgical stimulation. It is basically for inhalation anesthetics. Okay, the second question, neuromuscular blockers are mainly used for, your time starts now, surgical relaxation, mechanical ventilation, electroconvulsive therapy, and facilitation of tracheal intubation. So what are neuromuscular blockers mainly used for? Please read carefully. Mainly used for. Okay, your time stops now. Again, your answer is number 4. Facilitation of tracheal intubation. So surgical relaxation, yes, it is used for surgical relaxation, but surgical relaxation can also be achieved without neuromuscular blocking drugs. That is, with just induction agents, induction agent infusion, surgical relaxation can be reached as long as a deep plane of anesthesia is maintained. Okay. Now, mechanical ventilation, yes, it can be used, but in the ICU, it's not. We do not use neuromuscular blocking drugs for a long term for mechanical ventilation in ICU patients, as prolonged use causes upregulation of receptors and various other problems. Of course, it is used for electroconvulsive therapy. These are this is basically electrical impulses that are delivered to patients' brains for for depression and schizophrenia. And of course, we do use a depolarizing muscle relaxant like succinylcholine, as we require muscle relaxation for a very brief duration, because so that they do not basically, because you're delivering an electrical impulse to the brain. but it is not mainly used for that. So it is mainly used for facilitation of tracheal intubation, as tracheal intubation causes the maximum response. So surgical stimulation is what we use as the ED95. As I mean, basically surgical stimulation is said to be painful, but the maximum stimulus that is produced, maximum painful stimulus, is basically tracheal intubation, because of the various receptors that are located in the larynx and the pharynx. So the so neuromuscular blocking drugs are mainly used to facilitate facilitation of tracheal intubation. Now the next question. Succinylcholine is the preferred muscle relaxant for tracheal intubation because your time starts now. It produces rapid and complete paralysis of respiratory muscles with quick recovery. It does not alter heart rate and blood pressure. It does not cause histamine release. It does not produce post-operative muscle soreness. Why is succinylcholine the preferred muscle relaxant for tracheal intubation? Okay, and the answer is number 1. Okay, so it does not alter heart rate and pressure. It causes bradycardia because it binds, it stimulates the SA node, and it can cause bradycardia, SA node and AV node. It causes bradycardia, junctional rhythms. Blood pressure, as such, it has a dual action. It can increase or decrease the blood pressure because it has a complex, it stimulates the muscarinic receptors in the sympathetic parasympathetic system, as well as so it stimulates the sympathetic parasympathetic system as well as direct action on the cardiac muscarinic effect receptors. So it can cause either an increase or decrease in BP. But it does not cause histamine release. And of course it does produce post-operative muscle soreness. So succinylcholine basically leads to um, fasciculations. These fasciculations can cause post-operative muscle soreness. Okay, so the fasciculations are visible because this muscle relaxant is an agonist like like acetylcholine. As a result, it produces muscle contractions, which can be seen as fasciculations. Okay, so it does cause bradycardia, and plus or minus, uh, it can cause, because of the stimulation of the nicotinic receptors in the sympathetic and the parasympathetic ganglia and the muscarinic receptors in the SA node. Low doses of succinylcholine, like I said, low doses can produce negative chronotropic and inotropic effects, whereas higher doses usually increase heart rate. Heart rate and contractility, and increased contractility and increased catecholamine release. So it can increase or decrease blood pressure and heart rate. So it goes both ways, right? And it produces rapid and complete recovery of muscle paralysis. So recovery occurs within 9 to 13 minutes, and uh, onset is within 60 minutes. Okay, next question. Which of the following muscle relaxants is free of cardiovascular effects over the entire clinical range? Your time starts now. The answer for this question is pecuronium. So pancuronium is known to cause tachycardia, by vagolytic mechanism. So this causes tachycardia. Uh, Antracurium also, because of histamine release, can cause hypotension. Pecuronium as such, pipecuronium is not used. And again it causes hypotension because of histamine. So among these, pecuronium is your choice. It does have cardiovascular effects, but these have a mechanism for their cardiovascular effects. This is plus or minus. It is some studies have shown the pecuronium to have hypotension and bradycardia, but of course it has been used without any in the clinical range quite a lot with, and it is shown to be free of cardiovascular events. Your next question. Baclofen is, your time starts now, centrally acting muscle relaxant, peripherally acting muscle relaxant, both centrally and peripherally acting muscle relaxant, and direct acting muscle relaxant. Okay, the answer is number 1, centrally acting muscle relaxant. So basically baclofen is it's a centrally acting muscle relaxant, and it is antispasmodic. It relieves spasms. It does not have any action at the neuromuscular junction. Okay, your next question. True statement regarding depolarizing neuromuscular blocking drugs is. Your time starts now. The depolarizing muscle fibers are unresponsive to other stimuli, causes muscular fasciculations, not reversed by neostigmine, or all of the above. Okay, so your answer is number 4, all of the above. So the depolarized muscle fibers are unresponsive to other stimuli, that is so when succinylcholine, which is the depolarizing muscle relaxant, it is an agonist similar to acetylcholine. So when it binds to alpha receptors at the alpha on the acetylcholine, nicotinic acetylcholine receptors at the neuromuscular junction, when it binds to that, it produces an agonistic action initially, hence it is known as an agonist. Okay, so and of course your non-depolarizing are competitive antagonists, that is they compete with acetylcholine for the neuromuscular to bind to the receptors at the neuromuscular junction. So succinylcholine is similar to acetylcholine, hence it is an agonist at the neuromuscular junction. right? So when it binds to the nicotinic acetylcholine receptors, it initially produces a there is a uh, depolarization occurs. Okay, this causes muscle relaxation. So the sodium, it basically, so when it binds, the calcium channel opens, and there's depolarization. It binds to the sodium receptors, and there is initial depolarization spreads over the membrane. So this sustained depolarization, this depolarization does not pass off down the muscle fiber. It is a sustained depolarization, because what happens is the sodium channels get blocked in the inactivated states. So the sodium channels have three states, right? The active, inactivated, and the resting phase. So the depolarizing muscle relaxants binds to the acetylcholine receptors, but unlike acetylcholine, which is cleared by acetylcholine esterase, this does not clear by acetylcholine esterases. So it is continuously bound to the acetylcholine receptor over there at the neuromuscular junction. So it produces a continuous depolarization. So this continuous depolarization, initially the sodium channels are in the active phase, so it will bind and produce a depolarization, but slowly the sodium channels go into the inactive phase, and they will remain in that phase as long as the depolarization continues to be there. So from the active to the resting phase, they do not pass. So the sodium channels are stuck in the inactive phase. Okay, so and they cannot open again until they reach the resting phase. So it is the end plate cannot repolarize as long as the depolarizing muscle relaxants continues to bind to the acetylcholine receptor. So basically the muscle membrane will be separated into three parts. So the end plate depolarized by the muscle end plate depolarized by scoline, right? This is one part. Then your second is the perijunctional membrane, that is around your end plate, your perijunctional membrane, where the sodium channels are frozen in the inactivated state. Now, because these sodium channels are frozen in the inactivated state, they do not allow. So this perijunctional area is around the motor end plate. So this is your nerve. Sorry, this is your nerve. This is your muscle, right? So this is your end plate, which is corresponding with the nerve. This is the perijunctional area. So these receptors over here, so the sodium channels are frozen here. Because of that, the depolarization is not passed down. So the rest of these receptors, the sodium channels are in the resting phase. That is, they are not in the active phase because there is no depolarization passing to them. So the voltage gated sodium channels will not open. The sodium channels are in the resting phase. So this is a protective mechanism basically for the rest of the muscle. That is, there is no stimulation for the rest of the sodium channels. This is known as accommodation. So that is what this statement says. The depolarized muscle fibers are unresponsive to any other stimuli. So whatever stimuli comes and stimulates these receptors over here, there will be no reaction of the muscle because of this process known as accommodation. Of course, succinylcholine causes muscle fasciculation because it is an agonist, so it binds to the acetylcholine receptors, initially leading to depolarization, which will be manifested as muscle fasciculations on the skin. It cannot be reversed by neostigmine. Neostigmine is used to reverse non-depolarizing muscle. Basically, succinylcholine is cleared by butyrylcholine esterase or plasma choline esterase. So butyrylcholine esterase or plasma choline esterase, basically it clears succinylcholine in the plasma. So as the plasma concentrations decrease, then succinylcholine will diffuse away from the neuromuscular junction and be cleared. So the clearance of succinylcholine esterase depends on plasma choline esterase. It does not depend on neostigmine, which is an anticholinergic. So the answer is all of the above. Now your next question, long-acting non-depolarizing muscle relaxants are. Your time starts now. succinylcholine, mivacurium, pancuronium, phenylephrine. Okay. And the answer is number 3, pancuronium. So succinylcholine is it's not a non-depolarizing, it is depolarizing. That is, it is an agonist at the neuromuscular junction because it is similar to acetylcholine. Non-depolarizing are competitive antagonists. Basically, they compete with acetylcholine at the neuromuscular junction. Mivacurium is short-acting, non-depolarizing muscle relaxant, and pancuronium is the long-acting. Phenylephrine is not a muscle relaxant. Sympathomimine. Alpha adrenergic stimulator receptor agonist, alpha agonist. Okay, your next question. In the case of spasticity, the drug not used is, your time starts now. Diazepam, baclofen, tizanidine, amitriptyline. Okay, the answer is number 2. So it is a centrally acting anti-muscle relaxant and it can worsen the condition. So which of the following drugs is not a long-acting neuromuscular blocking agent? Time starts now. Doxycurium, mivacurium, pancuronium, pulpocurium. The non-depolarizing neuromuscular. Okay, sorry. So your answer is mivacurium. Sec. Your answer is mivacurium. So the short acting is mivacurium because it is rapidly again cleared by plasmacholinesterases. Intermediate is basically your vecuronium, atricurium. So this is how they are classified. Okay. Non-depolarizing. One is based on the chemical structure and one is based on duration of action. Chemical structure is based on steroidal compounds and benzyl isoquinolinium compounds. These are your benzyl steroidal compounds are vecuronium, atricurium, pancuronium, and your benzyl isoquinolinium is your atricurium and cisatricurium. This is based on the duration of action. Vecuronium, atricurium, cisatricurium, procuronium. and your long acting is basically your pancuronium and your pipocuronium and doxycurium. Okay, your next question. The following is the feature of a depolarizing blockade. Your time starts now. Tetanic fade, post-tetanic potentiation, progression to dual blockade, antagonism by anticolin esterases, diazepam. Okay, time is up, and your answer is, so basically the feature of depolarizing blockade, basically your succinyl choline blockade, that is progression to dual blockade. So tetanic fade and post-tetanic potentiation is a presynaptic mechanism that is on the nerve terminal, and this is seen with non-depolarizing and phase 2 block, which is rare. Phase 2 block with the depolarizing agent, but this phase 2 block you cannot take it into consideration when such a question is given. Okay, otherwise you do not see fade or tetanic facilitation because succinylcholine does not bind to presynaptic nicotinic acetylcholine receptors. So progression to dual block, that is your phase 1 block and your phase 2 block. Yeah, so phase 2 block, phase 1 block is what I've already explained to you in the previous question. Phase 2 block is due to desensitization of receptors. It is poorly understood, but it is said to be occurs with the second dose of succinylcholine or prolonged exposure to succinylcholine. There will be a phase 2 block, which ideally is reversed by reversal agent. So reversal antagonism by anticholinesterase. This is because succinylcholine is degraded by butyrylcholine esterases. Antagonism by anticholinesterase is a feature of non-depolarizing muscle relaxant. Okay, that is how, because it's a competition, they are competitive antagonists, so this helps, right? Diazepam is a benzodiazepine. It has no relation to this. Then comes your, the drug not acting on the neuromuscular junction is, your time starts now. Baclofen, sorry for the spelling, haloperidol, carisoprodol, all of the above. Okay, the answer is number 4. None of these drugs act at the neuromuscular junction. Okay, your next question is, the short acting non-depolarizing blocker is, time starts now. Rocuronium, suxamethonium, mivacurium, pancuronium. I have already just told you all the classification and everything, guys. You all should get this. Short acting non-depolarizing blocker. Sorry. Okay, time stops now. The short acting non-depolarizing blocker is mivacurium. Okay, I just explained to you all the classification. Pancuronium is long acting. Succinylcholine is depolarizing muscle relaxant, but and short acting. Short acting depolarizing muscle relaxant. Rocuronium is intermediate. It can be short acting and used for rapid tracheal intubation in higher doses of 1.2 milligram per kg. Okay, so rapid intubation that is when it becomes, it is not short acting, but it is intermediate acting only, but the onset of action is rapid. Onset is rapid with 1.2 milligram per kg. So in pseudocolin esterase deficiency, the deficiency drug to be used cautiously is, your time starts now, barbiturate, succinylcholine, halothane, galamine. Okay, the answer is succinylcholine, number 2, right? So pseudocolin esterase deficiency, because succinylcholine is metabolized by pseudocolin esterase. Oh, it's also known as plasma choline esterase. It is synthesized by the liver, okay, and it degrades succinylcholine in the plasma. So as the plasma levels of succinylcholine fall, that's when action at neuromuscular junction is terminated, because it diffuses away into the plasma to be degraded by this. Mechanism of action of curare is, your time starts now, reducing end plate potential, reducing presynaptic potential, inhibits potassium channels, inhibits sodium channels. Okay, so curare basically, the answer is number 1. It reduces end plate potential. So regarding muscle relaxants, which of the following is true? Your time starts now. Pancuronium causes bradycardia. Atracurium is contraindicated in renal failure. Cisatracurium is a depolarizing muscle relaxant. Pecuronium induced muscle relaxation can be reversed by neostigmine. Okay, your answer is number 4. So pancuronium causes tachycardia by like I said, a vagolytic action. Okay, atracurium is not contraindicated in renal failure. It does not depend on the kidney for its metabolism and excretion. It undergoes Hoffman's elimination, which is pH and temperature dependent. It has nothing to do, it is a chemical elimination, nothing to do with organ. So it is an organ independent metabolism and elimination, and cis-atracurium is a non-depolarizing muscle relaxant, not a depolarizing muscle relaxant. Phase 2 block. About phase 2 block, which is not true. Time starts now. Continuous exposure to depolarizing drug causes phase 2 block. Action is on the pre-junctional neuronal acetylcholine receptors, leading to fade. Electrolyte imbalance due to potassium efflux can disrupt the membrane, leading to phase 2 block. There is no response to tetanic stimulation. Okay, so basically your answer is number 4. This is untrue. Okay, so continuous exposure to depolarizing drugs leads to succinylcholine causes is one of the known mechanisms for phase 2 block. Phase 2 block is produced due to the action of succinylcholine on the pre-junctional neuronal acetylcholine receptors, that is on the nerve membrane. This leads to fade because the mechanism of fade is due to the binding to the pre-junctional neuronal acetylcholine receptors. Electrolyte imbalance due to potassium efflux can disrupt the membrane, causing a phase 2 block when there is too much of potassium efflux and there is no response to tetanic stimulation. This is not true because the mechanism of action is binding to the pre-junctional neuronal acetylcholine receptors, which produces a fade. So tetanic stimulation, the response to tetanic stimulation is basically a fade, right? So this is untrue. Which is untrue regarding butyrylcholine esterase or your plasma choline esterase? Your time starts now. Butyrylcholine esterase is synthesized by kidney and is found in the plasma. Half life of plasma choline esterase is half life of plasma choline esterase is 8 to 16 hours. Butyrylcholine esterase is responsible for metabolism of succinylcholine, mivacurium, procaine, chlorprocaine, tetracaine, cocaine, heroin. The activity of enzyme refers to the number of substrate molecules hydrolyzed per unit of time, often expressed in international units. It hydrolyzes succinylcholine mainly in plasma. Which of the following statements is untrue? Okay, the answer is, your answer is number 1. Butyrylcholine esterase is synthesized in the liver. Okay, and it is found in plasma is correct, but it is synthesized in the liver, not in the kidney. The half-life of plasma choline esterase is 8 to 16 hours. It is responsible for the metabolism of succinylcholine, depolarizing muscle relaxant, mivacurium, non-depolarizing muscle relaxant, chlorprocaine, tetracaine, procaine are all local anesthetics. Cocaine and heroin are opioids. Now, the activity of the enzyme refers to the number of substrate molecules hydrolyzed per unit of time. So, the activity of the enzyme refers to the number of succinylcholine molecules that is hydrolyzed per unit of time and is expressed in international units. So, the number of molecules that of succinylcholine that butyrylcholine esterase can hydrolyze gives the activity of the enzyme. Now, dibucaine inhibits normal enzyme approximately. Your time starts now. 80%, 20%, 60%, 30%. Okay, so dibucaine basically inhibits the normal enzyme approximately 80%. So this indicates the enzyme activity. So the amount that dibucaine that butyl. So Debbucane number is basically indicates the activity of butyl. Debbucane number. Butyl is a local anesthetic. It indicates activity of plasma choline or butyl choline esterase. So a normal enzyme, this Debbucane, inhibits the activity of plasma choline esterase. So normal enzyme will be inhibited approximately 80%. How much does the plasma potassium increase by normal individuals when they are administered succinyl choline? Your time starts now. How many milliequivalents will the plasma potassium increase by in normal individuals when administered succinyl choline? Equivalents per liter. Okay, the answer is number 2.5 milliequivalents. In conditions like burns and all that, the plasma with succinyl choline administration, the plasma concentrate potassium increases by 15 milliequivalents per liter due to upregulation of receptors. Extra receptors, immature and mature, both are expressed, and hence there is excess release of potassium. The first muscle relaxant to be blocked by both depolarizing and non-depolarizing muscle relaxants are face, jaw, pharynx, larynx in the order adductor pollicis, diaphragm, larynx, abdominal muscles, larynx, face, diaphragm, adductor pollicis, masseter. Okay, the answer is basic number 1. Face, jaw, pharynx, larynx, followed by your diaphragm, abdominal muscles, and finally your adductor pollicis, peripheral muscle. So this is the mechanism of blocking. So basically it depends on the, it's more depends on the blood flow to these muscles, how they are blocked. As a result, though the central muscles like diaphragm and abdominal muscles are more resistant to non-depolarizing muscle relaxants as compared to adductor muscles, but still they get blocked more quickly because there is increased blood flow to these muscles as compared to the peripheral muscles, and hence more amount of drug is delivered to these muscles, more receptors are bound, and hence quicker relaxation. The dose of neuromuscular blocking drugs, non-depolarizing muscle relaxants, needed to block the diaphragm and muscles of the larynx is 5 to 8 times that of the adductor pollicis, 0.5 to 1 times that of the adductor pollicis, 1.5 to 2 times that of the adductor pollicis, and 2 to 2.5 times that of the adductor pollicis. So the dose of non-depolarizing muscle relaxant needed to block the diaphragm and muscle of the larynx is. So like I told you previously, the diaphragm and muscles of the larynx are actually more resistant than the adductor pollicis to the action of non-depolarizing muscle relaxants, but due to the increased blood flow, they are blocked quicker. So in this respect, the dose needed to block the diaphragm and muscles of the larynx is the answer is number 3. It is 1. I'm sorry. It is 1.5. It is 1.5 to 2 times that of adductor pollicis. Non-depolarizing blockade is characterized by all except decrease in twitch sensation, fade during repetitive stimulation, that is TOF, post-tetanic potentiation, single quick stimulation produces fade. Okay, the answer is number 4. So single twitch stimulation does not produce any response in both depolarizing and non-depolarizing muscle relaxants, which is not true about non-depolarizing muscle relaxants. Speed of onset is inversely proportional to potency of non-depolarizing muscle relaxant. It is explained on the basis of density of receptors at the neuromuscular junction, irrespective of their potency. These drugs must bind to a critical number of receptors for blockade to occur. Most potent compound is cisatracurium, least potent compound is vecuronium. Okay, what is untrue is basically number 4. Okay, so speed of onset is inversely proportional to the potency of neuromuscular non-depolarizing muscle relaxants. So highly potent drugs will be slower speed of onset because less. So this is the basis of explanation, because a particular number of receptors have to be occupied. So less potent drugs, there is the quantity of the drug to produce a particular in a certain population, that is the dose of the drug, which is smaller as compared to the less potent drugs, which will have more molecules of the muscle relaxant. So most potent compound is cisatracurium and the least potent compound is rocuronium, not vecuronium. Main route of metabolism of pancuronium is liver, intestine, kidney, lungs. Okay, so your main route is basically your kidneys. Which of the following drugs undergo Hoffman elimination and ester hydrolysis? Mivacurium, cisatracurium, atracurium, and rocuronium. This is the last question. Okay, your answer is um, atracurium. So cisatracurium undergoes only Hoffman, no ester hydrolysis. Mivacurium is by plasma esterases, and rocuronium is degraded by liver and bile. Okay, so guys, that was the quiz for today. I hope it was. I hope y'all were able to analyze your performance based on the topics that I have taken. I will be preparing more quizzes for y'all based on the other topics that have been taken for y'all. So guys, that's all for today. Study, concentrate, get enough sleep, relax, do some exercise, eat well. You know, it's very important. Yoga or exercise is very important to de-stress yourselves. So get enough sleep. It's very important for you all to retain stuff. So that's about it for today. Please use my code, like I said, SASHA, to avail your 10% discount. Guys, hurry and subscribe so that I can help you all prepare better in anesthesia. Hurry. Okay, thank you guys. Enough for today. See you all on Sunday for the marathon session. Don't forget, to us, all the instructors will be covering topics. So these are special classes, not YouTube classes. These are special classes on an Unacademy. So